I'm working extensively on the treatment of failed surgical valves with valve-in-valve, which is performing TAVR inside failed surgical valves. This is my main clinical and academic focus for almost a decade now. And we know that there are limitations to that approach, but basically we see that there is, with good efficacy, we can treat failed surgical valves. Surgical valves, biological valves, tissue valves, they naturally may fail. The time to degeneration may differ between different types of surgical valves, but this is a natural phenomenon. We looked extensively on the cases performed in the pioneering centers performing TAVR in the early days, which were mainly the center in Rouen, France, and the center in Vancouver, Canada, looking at the early cases performed with early generation THV devices, mainly the Edwards Crebier and the old Sapien valve and the Sapien XT. We looked at cases that were performed earlier than 2011, and we aggressively tried to evaluate the performance of these valves in long-term follow-up. And I must say that this is a very tough project. It's very difficult to look at long-term after TAVI from many reasons. One of the reasons is that patients are very old. Patients that were going to TAVR in the early days had average age of 82. Not many of them survived long-term after the procedure. If they survived, they are very old now. They are approaching 90. Some of them are above the age of 90. They have non-cardiac related issues that make it very difficult to have them evaluated in the hospital later on. Because of that, we aim to evaluate that early cohort of TAVR population sometimes in their home or in their nursing facilities with echocardiographic exams that later on we utilized in our echo department to look whether these valves were working properly or they showed some signs of degeneration. There are many different thresholds of degeneration that we can apply for bioprosthetic valves. We looked at a threshold that is relatively minor, which is having mean gradient of 20 or above, or moderate aortic regurgitation in follow-up after the procedure. And we wanted to see how many valves meet that criteria of early degeneration. And we saw that in long-term follow-up, between 5 and 8 years, there is a cluster of cases meeting that relatively minor threshold of valve degeneration. Another issue of looking at long-term durability of TAVR procedures is the fact that in the early days, the procedure was not performed on many patients. So we needed to group the cases in Vancouver and Rouen. In Vancouver itself, it was a couple of hundreds of cases. If you take out those that died within 30 days or that had early failure of the device related not to degeneration but to technical errors, you end up with not many patients that can give you good statistical power to look at more significant thresholds like significant aortic stenosis, significant regurgitation, reintervention rates. This is a very complex field to look at. This is a very complex question, but in general, I believe that the vast majority of TAVR devices, if they fail, we can treat them non-invasively with another TAVR device. In the early days, in the 80s and 90s, before the TAVR field came, having a patient with a surgical valves, bioprosthetic valves, that started to fail was an issue, was a significant issue. Because we didn't have a non-invasive approach to treat that patient, and having a failed valve meant a need for redo surgery on an old patient. And therefore, it was a major issue. Nowadays, if we can do another TAVR procedure inside the failed TAVR, like we do inside the failed surgical valve, and that procedure would be successful, then I do not fear the generation of TAVR. I think that we need to continue to learn that topic. I think it's very good that the solid trials will extend the follow-up of their patients to 10 years. I think it's good that many centers look at their own data and try to bring patients and to do echo on them to look at the durability of these devices. I think that we need to continue and learn about new THV devices, because durability of new THV devices might be completely different than the early generation devices. There is a different treatment that was performed upon the leaflets of new THV devices. The paravalvular leakage rate in the new devices is lower than in the early devices. So the flow around them is different, and the degeneration rate might be completely different than what we eventually will see with the early generation devices.